Dear Pure Facebook viewers, good evening one and all. As you all know, we are doing every other day the surgical technique based presentations related to the urology. Today we are doing bipolar enucleation of the prostate. Last 2 decades, the treatment of the prostate surgery has changed a lot. Why? Because most of us are not doing surgery for symptomatically not bothered patients. That is the one reason. By the time we reach the symptomatically suffering patients, the prostates are large in size. So naturally, more than 60 grams prostates we are seeing more often now. And for this, TURP is, even though gold standard, there is always an alternative because TURP definitely bleeds. Even if it is bipolar TURP, also apart from preventing hyponatremia, the bleeding component cannot be reduced. And it takes long time. A lot of gland has to be resected. That also will take 1.5 hours to 2 hours, even in experienced hands. Previously, people used to finish everything in 45 minutes, 50 minutes. But it's not easy always in a large gland. So time constraint is matched with the bipolar enucleation. Traditionally, holmium laser 100 watts is ruled the enucleation part because it develops the plane by itself without any mechanical force. After that, bipolar enucleation with various types of loop have come. Predominantly, the Olympus loop has been there for a long time. After that, now Coral Starch has come with the Ferman loop, and then it continued. Last 2-3 years, because of the lasers availability has increased, everybody is attempting laser enucleation of the prostate. With this introduction, today we are talking only about bipolar enucleation of the prostate by Dr. Mohammed Taif from Hyderabad, which is the place we are also practicing. He is from Asian Institute of Nephrology and Urology, and I have seen him in front of my eyes, very sincere, hardworking, develop good surgical techniques. And in this, recently, I listened his talk in one of the conferences. I was impressed. So taking his unit experience as well as his experience in the unit, we thought we will request him to present on bipolar enucleation of the prostate. Hi, Taif. Thank you for being with us today.
Good evening, sir.
Good evening.
Thank you for getting on this prestigious platform. Thank you for your kind words of introduction, sir. It's a pleasure to be part of your platform here, sir. Thank you so much.
Taif, you did your MBBS from where?
So I am from North Karnataka, sir. So
North Karnataka.
most of my education has all happened in North Karnataka.
Which college?
Hubli, sir.
You are from Hubli primarily?
KIMS Hubli, sir. Yes.
Okay.
Yes,
You MBB MS from?
Hubli, sir.
MS is also from Hubli.
Yes, sir.
That time NEET was there or general statewide selection?
No, sir. State-wise, sir.
Statewide selection. After that, you did your MCH or DNB where?
In Karnataka, sir. Bellary. There's a place, Bellary, and I hope you know.
Okay. Bellary, I know very well. So you did in Bellary your MCH urology?
Yes, sir.
Who was the teachers when you did your MCH?
I did my MCH under Dr. Vasant Sheth and Dr. Imdad, sir. They were my professors.
Vasant Sheth.
Yes.
Okay. So what is your favorite surgery among all the surgeries as of now? If you have been given choice, one surgery to choose, only surgery, not the practice.
I think yes.
Like very most.
Sir, endoscopic enucleation, sir. You have got me for that same thing. That is quite close to my heart. So yes, enucleation.
I thought like that. I also thought that you are doing good enucleation procedure. Good. That means I have chosen the right point in you. I will share the screen officially introducing you. After that, I will hand over the program. So today topic is bipolar enucleation of prostate by Dr. Mohammed Taif Bendigeri. And Dr. Mohammed Taif is MBBS, MS General Surgery, MCH Gold Medal from Rajiv Gandhi University of Health Sciences. Operating faculty in multiple live operative workshops in endourology and laparoscopic urology. expert in transplant urology and andrology, currently working as consultant urologist at Asian Institute of Nephrology and Urology, Hyderabad, published 15 publications in national and international journals, multiple presentations in national and international conferences, authored 3 chapters in urology books, is member Society of Generative Neurosurgeons, Telangana State and AP, member of USI, member of Endourology Society. With this introduction, I will hand over the program to Taif. Over to you, Taif.
So I'll start sharing my screen, sir.
Yeah.
Are slides visible, sir?
Yeah, visible. Only you are audible.
Okay.
Nice.
Okay, sir. Welcome to all the audience.
Want to enlarge the screen? Bigger screen?
I have put it on the full screen, sir.
No, it is little lag is there, I think. It is still in the minimized.
I'll just change my...
No problem. It is visible clearly. You can proceed.
Is it better now?
No. It is visible, but it is not enlarged. Like a full PPT form, it is not there. Yeah, now it has come. That means
there is probably net lag.
there is little lag in the transmission. Just wait for 1 minute.
Sure, sir.
This is probably because of the video. Otherwise,
could be, sir. Could be possible.
This is probably because of the video. It is still not visible, the front slide. It is blank. You want to reshare quickly? No problem.
Sure, I'll try that.
Because it's not coming. Yeah, reshare, no problem. Yes. Did you enlarge the screen? Yeah, it's not coming. It's taking time. You can remove the video, no problem. Yes, very clear now, but enlarge.
Full screen now, sir?
It is in the minimized form only now. It is visible clearly. Now slides are visible.
Okay.
You do one thing, Taif.
Sir?
You close it, you open in your laptop and enlarged view, and then directly share that. Now you are rolling down.
This way you suggest, sir?
You stop sharing. Stop sharing, close it. Now you open in your laptop, enlarge the view directly. First slide, you go to the directly enlarged view and then share. Keep in direct presentation mode, direct. Now you go to share screen. No, it is coming as a PPT. What I'm saying, or else you do one thing, don't enlarge, directly present this. This is good.
Okay, fine.
Go ahead, please.
The topic for today is bipolar enucleation. So the basic introduction has been very rightly put across by you, sir, that there are a lot of limitations of TURP, and from there we have proceeded on to the process of enucleation. Multiple options have come up, and slowly we are trying to find out how one energy source and one modality of enucleation scores or performs in regards to another. So one particular thing that we would be discussing today is one of the modalities of bipolar enucleation. I have nothing to disclose. I would like to cover it, the present topic on why do we need enucleation, the options available, and the $1,000,000 question of which one is better, and the topic of today's concern, how to do it and what are the results. So why enucleation? Briefly, the most important reason is if you resect, there is often an inadequate resection to the tune of around 50% of the times. The retreatment rates with TURPs are very high. And if there is a large glands, like highlighted in the introduction, the chances of complications go up significantly. And if you look, the comparison between enucleation versus the previous bipolar resection, the results are significantly better in terms of enucleation. So enucleation scores significantly over our previous gold standard of TURP. And hence we can say that enucleation definitely fares a lot better as compared to TURP. The meta-analysis also shows that in terms of the amount of tissue resected, the hemoglobin drop, and the overall complications and quality of life all favors endoscopic enucleation versus a TURP. So once we change our mindset from a resection to an enucleation, the biggest question for us is, what are the options for endoscopic enucleation? Well, the story started from the highlight came into Holmium enucleation, but a lot before Holmium enucleation was begun, the initial endoscopic enucleation was with monopolar energy. However, the limelight was taken by the Holmium enucleation, and the story started with Holmium enucleation being compared with the previous gold standard of open prostatic enucleation. So we had multiple studies which showed that HOLEP and bipolar enucleation both were comparable to open prostatectomy. And multiple medium-term and long-term results have shown the efficiency of bipolar enucleation in comparison to open prostatectomy. And the results have been comparable to the open enucleation. So which means that endoscopic enucleation by HOLEP and by bipolar enucleation are comparable in terms of results to the gold standard of open enucleation. So if we want to choose only one, then we come across the dilemma of whether to opt for a TUEB, that is bipolar enucleation, or the Holmium enucleation. Multiple studies are slowly starting to come up to look into various parameters. Some studies show a difference in a few of the parameters, but overall, the safety and efficiency of both the procedures are right up there and not much of a significant difference between the two. Few studies have shown that the safety and efficiency is there comparable across all the patients, even in the patients on anticoagulants. So there's not much to choose between Holmium and bipolar enucleation as term of results is concerned. But eventually, I am looking forward to the results of this ongoing trial, which is comparing head-on bipolar versus Holmium versus thulium. I think this is one interesting study that would answer a lot of present-day debates and questions in a more elaborate manner. Coming to our present-day topic of how to do a bipolar enucleation, there's multiple techniques actually. It started off with initial usage of monopolar energy and bipolar energy and using the sheath as a leverage to do the enucleation. And then it has developed further with the use of multiple modified loops. The loops could be the one which is being used and which is shown in my video by Olympus, or the wedge-shaped loop by Stores, or even mushroom loops or multiple other patterns have been designed. The basically intention is to give a push with the loop in a controlled manner and to achieve a resection and hemostasis. If this is the one aspect which varies from one technique to another. The other modality which mainly makes a difference is whether you would opt for a complete enucleation, push the adenoma into the bladder and do a morcellation, or would you opt for an enucleation and keeping the adenoma attached in the fossa and opt for an in situ resection. This would be the other parameter which should change. how would we usually do at our unit is this technique. I'll slightly enlarge it if it is visible. Is the video seen, sir?
Yeah, it is video seen. You are enlarging in the PPT this thing, but
Okay, sir.
yeah, it is visible. No problem.
Okay, sir. So the main aims of the procedure would be giving mucosal incisions just beyond the adenoma and giving grooves at the floor and at the roof. So the first step is marking the mucosa just beyond the adenoma. So this is the schematic step which is being shown. So we make the mucosal incision all around just beyond the adenoma. So this is what is actually done. So just beyond the adenoma at the level of Veru, where the adenoma and mucosa joins, we make a marking on the mucosa all around. So that is the distal limit, and that is incised. So the mucosa is incised so that the further stretch is relieved from the distal sphincter. So all around slowly the mucosa is incised. Once the mucosal incision is done, we make grooves at 12 o'clock and 6 o'clock. So this would help in acting as a major landmarks during the enucleation, and also it helps in improving the irrigation flow. So once the two grooves are done, then we start enucleating slowly from 6 o'clock going to 11 o'clock. First in this video, it would be on the right lobe. So this is the loop of by Olympus, which has the tungsten element and the metallic element on top. The mechanical loop, which is the black one, is used to help the enucleation process. So we slowly proceed with the enucleation. The plane is created. We need to highlight and identify the proper plane, which is marked by the presence of these vessels running longitudinally. So these vessels are the plane, the surgical plane between the compressed peripheral zone and the adenoma. So this is the major landmark to identify that we are in a proper plane. So once the plane is identified, we start proceeding at the 11 o'clock to reach the bladder neck. So once we reach the bladder neck, we slowly start coming down at the bladder neck and coagulate the major bleeders at the bladder neck. So we would slowly start moving down here now. So we are moving at the bladder neck from above downwards. So this is at 9 o'clock, slowly proceeding down. The major bleeders will be coming across and slowly coagulated. So slowly start peeling it off from the peripheral zone and coagulating the vessels. So you can see it slowly getting stripped off at the bladder neck from the mucosa. So once this is done, then we start doing the same process more distally. So the rest of the adenoma starts getting devascularized and separated from the peripheral zone. So we have done it at the bladder neck. Now we do at the multiple levels from the bladder neck down to the apical region. So the same step by step is proceeded in multiple layers, multiple levels. So at 11 o'clock, then 9 o'clock, and then 6 o'clock. We would repeat the same thing again on the left side. So exactly the same step, going from 6 o'clock down to up to 1 o'clock and proceeding towards the bladder neck. So this circular movement is there, which separates the adenoma from the peripheral zone. So once you reach the plane, that will be the most important thing to note. So identifying the proper plane would be the most important thing to be followed in this process. So once you identify the plane, then you need to proceed and develop the plane slowly, step by step. At some times, if the fibrotic reaction is higher, you might have difficulty identifying the plane. And this is where most of the time the problem happens, that multiple planes develop. So that has to be taken care of. And you need to identify and reorient yourself, identify the proper plane, and slowly move towards the bladder neck. So exactly the same step is done again. And the separation of the left lobe from the major bleeding vessels at the peripheral zone is done, initially at the bladder neck, and then slowly progressing more distally. So separating the left lobe from the bladder neck, slowly peeling it off from the peripheral zone, and coagulating the major bleeders at the bladder neck. So once this is done, the bulk of the adenoma would have been enucleated and avascular. And then we get an option whether we need to detach it fully and push it into the bladder and opt for a morcellator, or keep it attached in the fossa and then resect it. So one technique that we follow is keeping the adenoma attached in the fossa, and in our technique, we keep it attached near the veru. So this is the final step of enucleation which is happening. The adenoma is getting slowly detached. So now, after this is done, the adenoma will be attached at the veru, and the only other areas which usually tends to get adhered to is at the roof, at the anterior fibromuscular stroma. So most of the time, this strip is usually held up, and you have to be extremely careful as to where you detach the strip so that the sphincter is not damaged and the chances of incontinence is reduced. So once this final strip of adhering stroma is released, the enucleation part is almost done. So it would be free across both the lobe, both the right and the lobe. Left lobe would be totally enucleated and in an avascular format. So the last step which would be left is just resecting the avascular adenoma from the fossa. The enucleation is totally done on the right and the left side, and it is held with only the strip at the verumontanum. So it would not dangle freely, and it would be there in an anatomical position without flopping, and it would opt for, we would opt for going for an in situ resection with the adenoma being held in place at the veru. One of the one of the techniques, improvisation which has been described is keeping it attached at the bladder neck instead of this verumontanum. So this is what is the final end result. Complete enucleation. We can see the plane, surgical plane all around, and few times small nodules might be there which would be getting into the peripheral zone, which has to be resected out. So this is the basic outline of the procedure that we do. And the results, what we have got published here is the results with regards to the efficiency is comparable across all the literature. The most heartening thing what we have come across in this enucleation is the blood transfusion rates and the clot retention rates are zero. So it's almost, we have not seen any transfusions or clot retentions for any of the larger glands in which we have done a bipolar enucleation. So that is the most important worrisome factor of a large gland PRP that has been taken care of. So I would conclude by saying that endoscopic enucleation of the prostate is always preferable compared to bipolar resection in terms of cutting down on the retreatment rates and the blood loss across, as has been highlighted in the literature. Multiple options are available to perform the endoscopic enucleation. Bipolar enucleation has been shown to achieve a similar result as compared to laser enucleation. However, the choice between bipolar, holmium, thulium, or a thulium fiber energy for achieving the enucleation still goes on, and it would be an individual choice to opt which one would be better. Thank you, sir.
So you finished exactly in 30 minutes, one of the early finished presentations. We will discuss some points because I am also doing enucleation with thulium fiber laser.
Okay,
the first question I wanted to ask is, this procedure has been done in for last 10 years in your unit.
Yes, sir.
So have you seen any change from early days to now, so that the incontinence is reduced? What are the, in front of your eyes, what are the changes that have happened?
The initial thing, the way we started off was also pushing the adenoma into the bladder and then morcellating it, which would need pushing from veru towards the bladder. There's a lot of stretch on that. And the initial, I would say the learning curve has been definitely very short. So very early on, the incontinence rates were higher. And as we noticed, the earlier releasing and adequately preserving the distal sphincter mucosa, that will reduce the incontinence rate significantly. So in our initial series, our initial transient incontinence rates were around 15 to 20%. But last couple of years, the transient incontinence rate, even on the day of catheter removal, has come down to less than 5%. So I would say now 1 in 20% leaks on the day of catheter removal, and it goes down to say almost 2 or 3% at the end of 2 weeks or 3 weeks. So, and most of the time, by the end of 4 to 6 weeks, most of them, more than 99% would have been gaining incontinence. The most important thing that I would like to highlight is across the literature also, persistent incontinence that we usually fear of is extremely less. 1% to even less than 1%, 0.5 to 1% is the persistent incontinence. We usually tend to get scared of with the transient incontinence, which is there.
My second question, apart from the physical examination, apart from the ultrasound examination, what the surgeon feeling when you go inside and see the endoscopic view? When will you not attempt enucleation? When will you not attempt enucleation? After going inside, what makes you, I'm asking, it's a smaller gland in perspective, not in the other way around. What are the conditions where you don't feel to do enucleation?
Sir, enucleation is the same, sir. Like the thumb rule, which was there from even open prostatectomies, the smaller glands are the more difficult glands to enucleate. Yeah. It is exactly the same even if you do a laser enucleation or bipolar enucleation. So, like we struggle to do open enucleation in a smaller gland, though it would have been reported as 100 grams, and the minute you feel it is less than 60, you know you are for a tough case if you are persisting to stick to enucleation.
So it is the same with, you don't stick like that and you will do TURP better.
If it is a smaller gland, it is always better, sir. I think even with whole
not very prominent lobes, not very large, not very vascular, just hugging lobes with a little bit of less vascularity, fibrous type of things are not good for enucleation.
No, sir, definitely. We have seen that across even with bipolar enucleation and also the HOLEPs that we do. The smaller glands always are more difficult to create the plane and to carry it out. Even HOLEPs have been very smooth if it is 60, 70 plus glands only.
Yeah. So that what capsule should be there.
Yes, sir. The development of surgical plane has to happen.
It has to be there.
Yes, sir. The pathology and the principle remains the same, sir.
Okay. Third question. Normally, see, if you see all the laser enucleation, initially they used to cut a deep groove on either side at 5 o'clock and 7 o'clock, irrespective of the median lobe. And then started going at the veru and cutting the mucosa all around anteriorly, laterally, posteriorly. Completely cut off the mucosa and then start enucleating from the distal to the proximal as a three pieces. Slowly what happened recently, everybody started attempting not at all touch the bladder neck, go directly to the veru, cut the mucosa, go into the para-veru grooves and directly go to the anteriorly, adequately you incise and then start enucleating.
En bloc dissection.
En bloc dissection. This is what recently a lot of the people are enjoying. So, do you find any difference with bipolar enucleation when there is a large median lobe? When there is a large median lobe, loop is a U loop. It is not a large, it has a large surface area. Even though it is very, very rigid, very, very thick, it has a large surface area. It is not a pointed like laser. It does not have an edges like a Fermat's loop. So, when you are coming to the mid-prostate region or at the base of the prostate, when you are pushing, a little bit of push and rotation is required. Do you feel difficult those cases where the capsule can little bit perforate or enucleation may be difficult if you don't remove the median lobe? My precise answer is median lobe resection with the loop and then go with the lateral large lobes is better, or you can do en bloc same like in laser enucleation in bipolar or not.
Sir, we don't usually opt for a en bloc resection, sir. No,
En bloc
because
not opted.
because en
So I
bloc,
got the
yes,
answer. Yeah.
yes, sir. En bloc is preferable more for glands of 60 to 80 or 90. So anything
large
more
gland,
than that,
you don't prefer en bloc because it put pressure on either side when you are
a lot of stretch, sir. There will be a lot of torque which is there, irrespective of the energy that we opt. Irrespective, yes, sir. Even with HOLEPs also, we never do the en bloc resection.
En bloc.
So even if it's a large gland,
also you are not doing en bloc.
No, sir. No. If it is fairly manageable, say 60 to 80 kind of a thing or 90, then en bloc is definitely comfortable. The minute you're dealing 90 or 100 plus, whether it is bipolar or the HOLEPs, en bloc is doable, definitely doable. But pushing the gland across into the bladder becomes a lot more tricky. So the advantage that is quoted, I think there is a significant interpersonal choice part there. So I'm comfortable with doing lower bladder.
That I agree. Now my fourth question, I agree that large median lobes one needs expertise. If you have difficulty, don't be crazy about en bloc. Reject the median lobe whatever way you want, whether you enucleate.
But eventually the results are the same.
Eventually the results are same. My fourth question is, nowadays you see people are starting enucleation in the retropubic region anterior aspect, where horizontal sheet, especially with laser, or the beak of the beak, if you are not using the loop. See, loop has a different configuration altogether. It has a vertically down structure, whereas the beak of the scope or the laser has an end on. So what people are doing now, what I am also enjoying is, develop a plane first in the retropubic region, on either side 10 degree, 10 degree, 10 degree. Don't bother about the floor at all. Come slowly on either side, almost go parallelly up to the bladder neck. Keep on sweeping on either side. Can it be done with the loop? It looks for me difficult because loop doesn't fit so well in the retropubic region, whereas it suits very well in the lateral part. What is your
answer? It can be done. It can be done because we totally reverse the rotation orientation. It can definitely be done, sir. So in fact,
you can develop the plane in the beginning retropubic also easily.
Yes, sir. But I wouldn't suggest directly trying to probe for the plane with the loop in the anterior part. Rather, I would suggest that identify the plane and then sweep across to 11 o'clock and then develop it going towards the bladder neck. So that, because there anatomically the plane is not different. All the planes merge together. So there, when you would be relying on a natural plane, you might have difficulty if you're looking to identify the plane as a first step anteriorly.
This is the only, because recently thulium fiber laser I am doing, I am finding little easy. If I push, even though the gland is not
with
there.
Lasers it is, yes, sir. Definitely, like you highlighted.
Because it is the only place it is horizontal.
Yes. With lasers, yes. With lasers, it is an advantage. We can do it with, yes. With the holmium or thulium, when we do, we can definitely do that very easily because we are not relying on identifying the natural plane. We have a slight amount of margin for error there. So definitely, whenever we do with lasers, we can do that.
We can do retropubic. Next question. Normally, when you do enucleation of the prostate, why do you think apart from cost effectiveness, attaching to the veru, you told clearly, you have shown in the last 10 seconds video, nice mucosa was attached to the veru and you detached in the last. Now, contrary, everybody is saying that apical release, apical release, apical release. The sphincter, not only you have presented many times, the lysosphincter, everything, the length of the mucosa between the veru and the sphincter original, the attachments on the posterior and anterior aspect, all these will be little, you have to careful mucosa beyond the veru also release in the beginning only, so that when you are pushing, there won't be pressure mechanical on the sphincter. So my precise question is, instead of using the resection at the end, traditionally which your unit does, why not marcellation and totally go to marcellation? What is in your mind when you are doing pieces? Because there is one disadvantage is you have to enucleate all the pieces, not only cutting. All the 100, 200 pieces, we have to enucleate. I mean, you have to evacuate also. So, given choice for you now you are also evolving as a junior bipolar enucleation surgeon. Do you stick on same like senior who is doing the resection, or you go for the marcellation? Given both choice, you have a good marcellator, everything available with you.
Sir, if the marcellator is working good, definitely there is nothing against the marcellator. I would definitely opt for a marcellator.
You will go for marcellator. Okay, yes. I got that. No discussion. Because when you cut it, people will feel that no time to.
It takes, yes. It tends to take time in the initial.
Thoda conferences mein, we used to feel that same thing we are doing again and evacuating. So now I felt that marcellator, once it's good condition, as you said, it's important. If the marcellator is good condition, I am taking 8 to 12 minutes of time. I hope everybody takes it properly. Good blades, first time blade it is using, it will come like that.
Yes.
Achha, last couple of questions. In multiple nodular BPH, this is a common problem everywhere. Most lateral aspect we may not go when you are sweeping. In other way around, I'm asking that, do you agree that the mechanical part will be maximum in bipolar, next is in thulium fiber laser, least in holmium laser? If you see very experienced holmium laser versus very experienced bipolar, they don't use any, for example, in erythroplasty, people say just pass the rod simply with your finger. Like that, they just rotate with, even I have not done like that. Only the tip of the laser fiber will be acting, especially in holmium. That is probably not possible in enucleation. What do you say?
Yes, sir, definitely. So if one gets the feel of the holmium laser cutting across smoothly, you actually tend to fall in love. So my personal choice, definitely. Literature.
Again, yes, if the cost is same, 100 watts laser and bipolar cost is same, definitely.
Like I highlighted, there's a lot of individual choice here. The literature does not show any advantage. But yes, if you have all the four, definitely my personal choice is holmium, sir, because you tend to fall in love with the way it creates the play.
Even that I am not getting with TFL, but holmium, they don't move the scope at all. They don't do sharing effect with scope. They just laser fiber separates the gland.
So we have all seen that. In our unit, we have sort of a natural randomization happening with Malikan sir having a liking more towards bipolar enucleation, and I have a liking more towards a holmium enucleation. So we are having sort of a natural randomization happening. Very soon we will have a randomized literature also. I would usually tend to correlate it that bipolar enucleation is like utilizing the blunt dissection with in the plane. You identify the plane, and if you are in the proper plane, it is like mobilizing the colon. Hardly any energy makes some.
Honestly, 60 to 80 grams it enucleates very well. If you have a technique.
And actual thulium laser is something like playing with the knife, and it finds its plane. Whether you find the plane yourself or no, it tends to identify and make a plane by itself.
That's not the whatever said and done. There will be some amount of charring will be there.
Yes, you have to be extremely cautious not to leave behind and keep the charring to a minimum.
Yeah.
Holmium and yes to thulium fiber, it is something like doing with knife dissection. You identify the plane and you will enjoy doing the knife scissor dissection. So holmium is something like a scissor dissection.
Yeah.
You would enjoy performing the dissection.
Knife and scissor. Thulium fiber laser is somewhere in between these two. Now I am using thulium fiber laser more, but only thing is cost effective again with 60 watts, whereas 100 watts is nearly 70-80 lakhs and 60 watts is nearly 40 lakhs. Enucleation is nearly 20 lakhs. It's like 20 lakhs, 40 lakhs versus 90 lakhs. To have the best with the 80-90 lakhs. And also depends on
having all the options available at any given point of time would be a luxury.
Yeah, luxury. And last question. What is the, when in your experience, when you felt that I am not able to do it, come on, I will switch over to TURP, this is not happening. Is it the large size of the gland or is it the infection leading to prostatitis among these two or prostate biopsy? When you felt that, oh, it's not worth and taking a lot of time and you get exhausted with enucleation, when?
2 points, sir. One is like you highlighted in the one of your initial questions in the small gland.
Yeah.
Say like you have been given an ultrasound report of 80, 90 cc, but the minute you go in, you know yourself that it is less than 60, it is 50
Yes.
or less than that. And if you are having a prefixed mind that no, I am going to do enucleation, then you are in for a tough time. So that is because of your inherent bias and a rigid approach towards the case rather than having an open-minded thing. That would make life difficult. And by the time you are through with the case, you will realize yourself about the mistake.
You made a mistake.
The only other difficulty is if you tend to lose the planes multiple points of time. Again, it is more common in a fibrous gland and relatively smaller gland. So you are very keen to, yes, I have to do and finish my learning curve. And there we tend to push even a 50-ish gland to do a enucleation. I need to cover my learning curve. That is actually a counterproductive thing. And you try to find the planes in a relatively fibrous gland, which would be rather a very simple, straightforward TURP. You end up doing a very struggling enucleation, and that would be adding to the frustration. And that is one of the reasons that I've heard many people moving away from the initial attempts at enucleation. They start enucleation, selection of cases will be usually biased, and again the decision will be left behind, so that it's better to stick on to TURP kind of thing. So because of that small issue.
Large gland you will not be that much afraid, but small gland you are afraid.
Yes, sir. Large gland it's actually more smoother. You will never repent opting for enucleation.
No, because your mechanical movements will clearly.
The plane is already defined. You just have to complete the.
Clearly understand how it is sweeping away, and you will enjoy it actually.
Yes, definitely.
Really enjoy it. Fast it is actually.
Yes, sir. Yes.
And last, not a question. My when I started enucleation, initially I had resistance because of the incontinence in private practice is very difficult to convince. After I have taken bipolar with Olympus and started doing, the only disadvantage was buying the 12-degree scope. Now, what I am realizing with thulium fiber and a normal working element with a laser fiber attachment in coral starch is 30-degree. So is it that the loop design is deciding the 12-degree? Because in Herman's loop, they are not advising 12-degree.
The Olympus loop is angled in such a way that if you are doing with the 30 degrees, you will not have the visibility of the loop.
You will not have the visibility. It is
relatively end on, so you need to look in front rather than downward vision of 30 degrees.
Yeah. So for all the juniors who have passed out, if they are initially financially not that good, bipolar TURP to bipolar enucleation transition period is better, or they can, after seeing all these videos and internet and attending the conferences, they can directly attempt enucleation. What is your take-home message for just passed out? See, everybody does URSL and TURP. These are the two surgeries, bread and butter. And everybody knows how to do it most of the times because their bosses also give, and they are common surgeries. So if they have to buy, bipolar TURP is 12 lakhs, bipolar enucleation is 20, something like that. You have to buy this loop and all the things, the extra 12-degree. So do you say that few years better to do bipolar TURP and then go to bipolar?
Definitely, sir. Definitely. Your expertise and the orientation with the TURP has to be completely thorough. And I would suggest only then proceed to trying the enucleation skills. If you are having the mentorship in the department or during the residency, yes, totally different thing. But otherwise, the general thing is you can manage a fairly average size of a gland by the end of your residency for TURP. But when you decide to try your hand with the larger glands and enucleation, you should be fairly confident that in case you are not, if you're not able to do enucleation, you should be able to bail yourself out by a TURP. So that amount of expertise has to come.
Excellent. So thank you very much. We in fact finished short and cute 44 minutes. And thank you very much once again. We will keep sharing the knowledge required. I will call you again for any expert surgical technique you develop.
Sure, sir.
Thank you.
Thank you so much. Thank you, sir.
Thank you very much. Good.